I've been in those seats, so see some familiar faces up there. I matriculated the program in December of 2015 from OU. Dr. Neal was there when I started, and some of your other staff as well, Professor Bean and Jessica and some of the others as well. I work at Integris Spine and Neurological Surgery. Been there for a little over a year. There is a team of 7 of us. It's a pretty unique setting, and it's a pretty special setting, I think. There are 3 neurosurgeons and there's 4 PAs. We are given a lot of latitude as far as, in general, we're given a lot of latitude as far as what we're given the opportunity to do in terms of participation with patients, and be it in clinic, in surgery, in hospital rooms. Does anybody in here have any surgical experience from shadowing or family or personal experience? Where are you guys at? Where are you guys at in your training program?
7.
And you guys are in neurology. I heard you guys already had neuroanatomy. One of the best, I would say. What do you guys think of all that? Okay, good. And you guys are doing okay with the summer program? Everybody's enjoying it? What have some of your experiences been in surgery? Those of you that have been exposed to it a little bit.
I did a nursing program prior to this, and I did my leadership rotation in OR. So anything from orthopedics to heart surgery to removing tumors,
So I will take you guys through the lecture. You guys can all read a PowerPoint, and we'll go through it. I'll probably go off the script periodically. You guys are welcome to ask questions. I'm not going to have all the answers. That's one of the first things that becomes very apparent is, or at least became very apparent to me, is the more you know, the more you realize, the less you know. So I'm not above saying I don't know, or I'll look it up, or you look that up, or anything in that nature. And I work with physicians and neurosurgeons that have been through over 10, 12 years of training, and they still use one another as resources on the regular, and it's very common that they'll look things up, or we'll look things up together. So that's an ongoing learning process, period. So I'm going to start with just a video. If any of you have queasy stomachs, you may not want to watch. Just to kind of give you a little bit of an orientation of what things look like when we are in the OR and we are seeking to debulk a tumor, basically retrieve it and usually get pathology or decompress whatever neuropathic deficits that they're actually having. I don't know if this has any audio, and I don't know if we want to listen to it actually. So this is looking through a microscope. That's the dura there. This is actually an awake craniotomy. I personally have not done any of these. The neurosurgeon that I work with, he trained back east, and he has done 3 or 4 of these at Baptist, to my knowledge. Unfortunately, they were there before. He did them before I joined the team. But I have seen a couple of the patients as outpatients and having conversations with them as far as kind of what their experience was being awake during brain surgery. It's no pun intended, it's kind of mind-blowing. But so obviously they're retracting the dura. I don't know about you guys, but we always had everything on super speed because that's what we have time for. So let's speed it up a little bit. So obviously you see the meninges, the dura is retracted and exposed, and then it's a process of using what we call a stealth navigation system that is in conjunction with really amazing computer software and MRI imaging, and we're able to localize where the brain tumor is within the brain have the imaging monitors in front of us, and then obviously the patient's head is exposed, brain is exposed, and we're able to figure out where the trajectory is and where we need to localize our focus as far as removing the brain tumor. This particular one, obviously one of the big concerns that they would have, not knowing anything about patient history or anything, you've got your sagittal sinus. You have to stay on top of that, and you don't ever want to have profuse bleeding. That's a bipolar cautery right there that they're going through and cauterizing the vasculature. So obviously the tumor is now exposed. We use something called fluorescein dye in order to kind of distinguish the margins of the tumor and try and remove as much of the mass in the tumor as possible without removing any viable brain tissue. So obviously, whenever the brain is always going to be beating, that's good. That kind of freaks people out. Sometimes when we do craniotomies and actually remove the skull bone for, like if we have to do a decompressive surgery and actually remove a bone flap and put it in the abdominal tissue to then replace later, just to give the brain some time to relax essentially. You'll see these patients who have their scalp tissue is healed and they still have a little pulsatile motion there, so that they often will wear hats because most people are not used to seeing people's hands beat. That kind of gives you an idea of what things look like. Do you guys have any questions about that? Just keep on rolling. Does everybody want to get in and do some brain surgery? It's kind of like an anatomy lab, right? It's pretty fascinating. All right, so, second most common form of cancer in children, accounts for 3.5% of all deaths in 1 to 14-year age group. Sixth most common cause of cancer in adults, 25% of all tumors in adults are in the brain. And it's the third leading cause of cancer deaths in people aged 15 to 34. I do have some notes at the bottom when they're there that you guys can just refer to, as you want to. Gliomas are roughly 50%, meningiomas are 25%. Gliomas are they have a much higher morbidity, and meningiomas are benign. We probably see more meningiomas in our practice than GBMs, gliomas, astrocytomas, which is a good thing because those are unfortunately generally a lot sadder outcomes. A lot of metastatic disease, we see that quite often. It seems like in my time that I've been there, we've seen more metastatic metastases to the brain than from lung cancer than anything else. Glioma is obviously a general name for tumors of neuroglial origin. So, glioblastoma multiforme is the most common primary brain tumor in adults, and it's the most malignant. Mean age is 55. Clinical history is usually less than 3 months. About 4 months ago, we had a patient that was working in a very high-stress professional field. And the father of 3 kids, had a wife who was also in a high-stress professional field, and he presented to the ER. Initially presented to an urgent care, and for a headache, they gave him a shot of Toradol and Benadryl. Didn't help the headache. He went back to work. He was working this whole time, noticed a little bit of visual disturbances, and was having intermittent headache that was not abated by NSAIDs or the typical Tylenol or anything like that. he was in the medical field, so one of his friends said, well, why don't we get a CT? They got a CT and they saw a mass, and they transferred him to RER, and ended up taking him to the OR the next day and doing a craniotomy on him, debulking the mass, and sending it off for pathology. It took roughly three days to get the final path on it, and it was GBM. It was a very aggressive form, and unfortunately, within the next 3-4 weeks, he died, which is pretty abrasive. It is not, it's very aggressive, it's very unforgiving. But that was one of my first experiences with something that pronounced and that aggressive of the GBM form. And, he's somebody, when you see these images, and I'm going to show you some images in the next couple slides too, the irony, to me, the irony of it is you see these abnormalities and pathologies in the brain, but these people will be walking around, talking. I mean, they might have some aberrations here and there, but I was an MRI tech before I went to PA school, and an X-ray tech, and it always just absolutely astonished me when these patients would come in. I'd kind of get a history, and okay, so we're looking for a headache, we're looking for this or that, and then I would do the MRI imaging acquisition, and then see these tumors in there. I didn't have the medical knowledge to understand as much as I do now, obviously, but it was absolutely astonishing, and to this day, it's still surprising what can be present in a person's brain, and it can still function at any high capacity for a short period of time, unfortunately, in women's cases that are referring to. So etiology of CNS tumors: gliomas more common males, meningiomas more common females. Ionizing radiation is implicated in meningiomas, gliomas, nerve sheath tumors, and primary CNS lymphoma associated with immunodeficiency. There hasn't been any evidence that shows that trauma or occupation, diet, anything like that actually links to CNS neoplasms. So I'm going to ask one of y'all to come up here and help me. Who's good at writing on board? So these are patients that we've seen. I'm going to kind of talk you through how they presented to us, and I want you guys just to obviously have the images there. Dr. McNeil said you guys have radiology this afternoon, so has anybody looked at the MRI before? Really? Okay, so let's just, orientation-wise, just get this a little quicker. Doesn't work on the computer, but yeah, the stick. Stick, I love the stick. Okay, so just for MRI, so we'll look at this one. I think when I was learning how to look at MRIs, one of the best things that somebody described to me was to think of it like a loaf of bread. You've got, your subject like a loaf of bread. You've got individual slices, you take a slice out and you look at it, right? So this particular slice is the axial. This is the anterior surface, this is posterior. Everything's opposite in radiology, so this is left, this is right. This here is the tumor. That's the abdomen. I'm sure you guys picked up on that. But the slices, literally, they just go like this. So the axial slices go from bottom to top, okay? So this is literally about right here. So as if you're taking it out and you're looking at it. This is your coronal plane. So this is back to front, okay? So you're just taking out a slice and looking at it. Right here, I'm putting that right here. So this gentleman is a 60-year-old man, so I'm going to have you guys help. What's your name? Sam. Sam. Nice to meet you. Thanks for help. I'm going to have you guys help Sammy just kind of point out what you think is significant of the history and as well as the physical exam. And I'll kind of take you through what we initially did. You guys can kind of figure out what we do for the initial workup, and then later on we'll come back and I'll kind of tell you how the course went and what the post-operative findings were, how they recovered or did not. So Mr. Fnell came to us to the ER, and and he came with his wife, and he had been, experiencing some dizziness, some disinhibition. He wasn't as motivated as he used to be. He became a lot more kind of somnolent. He was a very, not gregarious, but he was a pretty happy guy, generally speaking, but he, over the course of the last couple of years, prior to presenting to the ER for headache and some vision loss changes on the outside, that's what brought him in, headaches, the dizziness, and the vision changes. And so of those things, obviously, let's go ahead and write, 60-year-old male. So he's diabetic, he's obese, he's hypertensive, comes in, he's got a headache, pretty severe, vision changes. What are you gonna get? Gonna get some imaging, right? Gonna get a CT. Usually they'll start without contrast. On his physical exam, really the only differences were that he had vision loss on the outside, everything else. Oh, and that he had changes in his taste, as well as decreased capacity to smell, so olfactory nerve changes. You guys gotta help her, you can't make her do all work. Come on. All right, anything else?
Do you have write down the symptom?
Yeah. And then 5240 vision changes. What else did I say that was important? When you look at this picture, what lays right here? Your olfactory nerve, right?
Mood changes?
Loss of smell. Right here. So that is patient number 1. So now, go on to patient number 2.
I think it's today.
Anyway, okay. So now this gentleman is a 63-year-old man, that's be number 2. He presented to the ER with decreased capacity to speak, to retrieve words, which would also be called expressive aphasia. He was able to write, so when we communicated with him and did our workup, we had to ask him questions and then have him write and indicate yes and no. That was his biggest symptom. He had headache and word retrieval issues. He had some confusion for 4 days. He had a 30-year history of smoking 2 packs a day. Alcoholism. Some mental status changes. One of the challenges with him is he's pretty isolated. He lived by himself. The only family that he had lived in Ada as an aunt and uncle. So you have a patient that can't express himself. He can understand. For instance, I would ask him a question, and I would ask him if he had a headache, if the medication had helped for his headache. He would say no. And then he would laugh because he knew he wanted to say yes. But all he could say was yes, no, and it was a struggle to try to find those words. That did get better after surgery, which is good. So that is patient number 2. So what's in the left side, left hemisphere, predominantly? Wernicke's, Broca's. And then you've got the articulate gesticulations that help create that path. All right, so here is another one. This is 58-year-old number 3. This gentleman was a transfer from an outside hospital. Did not really have any significant history at all, with the exception of the preceding couple of weeks. He had had some memory issues, he had some headache, he had some confusion. had some difficulty with speech and was also had some gait ataxia. One of the things to pay attention to on this image is, again, we're in axial plane, we're right at the top of the orbit. So this here is the frontal sinus. Do you guys kind of know where we're at? This is the frontal sinus, left side, right side. The abnormality that we're looking at is right through here. It's more diffuse, it's not as well demarcated as the others, but one significant component is this is the midline of the brain. So you have pressure and it's crossing the midline. So that's also contributing to vision changes, headaches, and his overall clinical picture. He presented and was initially worked up for a right-sided MCA stroke. He was a puzzle. We had to do a lot of people on board trying to figure out what was going on with him. He did not have a stroke. He was worked up for a stroke and we treated him like that initially. Then there was indication, which your guy that comes and talks this afternoon might be familiar with this case, Dr. McNeil, because we have a lot of people lay eyes on it. But herpes simplex encephalopathy is what we were hoping for. It was a pretty abrupt change for the family. So the social aspects of any of these situations is usually a challenge because oftentimes in these younger patients, nobody's in. But we ended up taking him to surgery and having to get a biopsy, and I'll tell you more about that when we come back to it. So this is a 44-year-old lady who so her HPI, I'll just read it to you, okay? 44-year-old patient complaining of progressive difficulty walking for 1 year. You guys pick out what's important. You're making her do all the work. You guys, don't be lazy. Come on, help her out. Seriously. Otherwise, I'm going to start going around the room and having you all help her out. Progressive difficulty walking for a year. Patient states that over the last year or so, she's had increasing difficulty with gait and frequent balance issues. Patient and her daughter both state that she has been bumping into things and falling frequently. This is being more pronounced over the last month. She's intermittently confused with increasing memory dysfunction over the past several weeks. Worsening headache, but denies having any nausea or vomiting. Patient also admits to some very slight speech dysfunction over the past couple of months, and daughter noticed that she had a right-sided facial droop in a picture that she had taken several weeks prior to her presentation. Patient also has some difficulty swallowing, but has been eating okay, not coughing or choking. For her physical exam, she did have some right-sided facial drooping. You write down his face.
I'm also all of this.
Okay. So on like pronator drift, she had a right-sided drift. Memory was poor, 1 out of 3. You talked to her or asked her to remember something, you're like, we look at the hands, fingernail, as far as physical exam. She could remember 1 if you asked her about it a little while later. On her tongue, when you asked her to protrude her tongue, it would always drift to the right. It's kind of standard. She couldn't really get that protrusion. And then also she had diminished hearing on the right.
Diminished hearing.
Positive density bilaterally. Everything else was normal for the rest of her exam. She had bilateral positive density. All right. You got all that, you got all that. And then, so this is, I want to say their names because they're familiar to me, they're all people to me. So this is another patient that we had. Now this is a little unique situation in that this gentleman had a previous tumor debulking craniotomy, and he already had known small cell lung cancer. The family was very There's a lot of denial that goes on with things. If you or your family members don't have an advance directive, do yourself and them a favor and get one. Because it takes a lot of pressure off people and don't tell us. God forbid you're ever in a situation where you need it. So you can see actually on the picture on your left that the brain metastasis is really not that big. He actually had some right-sided myotonic dysfunction with fasciculations, memory dysfunction, headaches. He came in through the ER as well. I noticed a pattern there. And then the right side, his grip strength and his tricep grip strength, all that was diminished on the right too. So the HPI for him, I'll just give it to you. 58-year-old patient with past medical history of AFib, metastatic small cell lung cancer, status post initial chemotherapy. You don't have to write all this down. So he's had 2 different forms of chemotherapy, and he presented to the hospital on June 4th with hemoptysis and possible pneumonia. Patient is on blood thinners. CT scan demonstrated that a mass was in the left parietal lobe. A prior biopsy and resection by another doctor in March of the same year. Patient admits to progressively increasing numbness and tingling in the right hand body, numbness and tingling in the right arm, right leg, vertical obliques, which has progressively gotten worse. Patient also reported weakness in his right arm and having some difficulty with right hand motor dysfunction. His thing was, my right hand is doing its own thing. That's what he kept saying. That gives you guys some ideas of what different presentations can look like. And like I said, we'll go through everything and we'll come back to that. And we'll work through what the reports look like. Thank you very much. So classification, tissue of origin. So tissue of origin, location, primary, secondary metastases, grading, staging. You guys will get this at some point. You'll see it once you get out and start practicing. The type of tumor, number of mets, the number of nodes. You guys will probably be exposed to that most on your general surgery rotation if you have one. It's colon cancer, they're all about getting as many nodes as they possibly can because it's demonstrative of kind of prognosis and everything else. Tumor grading. The microscopic appearance, I would say that, obviously my perspective is surgical, so we see the images on the MRI. The meningiomas are nice, usually very nice and well formed, have nice margins, and are encapsulated well. When we're actually in there surgically, we can oftentimes literally just kind of retract the tissue around with cautery and scalpels if need be. Sometimes they'll just kind of pop out. It's really weird. Then there's others with your astrocytomas or your GBMs where it's just this messy, gooey stuff. It's a big difference. So if you're going to have a brain tumor, you want to know more of that story. You guys can read through that. So classification of CNS tumors, intrinsic tumors account for virtually all tumors in children. Extrinsic tumors arising from cranial and spinal nerves and dura, or tumors arising from adjacent structures, i.e. like pituitary gland tumors and metastatic tumors. The first brain surgery that I ever saw, I had a dental appointment the same day, and I'll never forget it because it still hurts me. It was a pituitary tumor debulking, and they go through transsphenoidal. So literally they have utensils that look like they're like this, and they literally go in and they work with the ENT, and they literally just go back to the little sphenoid and make it in there, and then just sell a Turska and just debulk it and pull it out. But don't ever have the dental appointment on your same day because it will go into your head. If you ever get a chance to see one of those, it's after you get over the initial shock of the things that are going into a person's little nose, is pretty fascinating. So, sites of cerebral tumors, supratentorial. 66% of tumors in adults and 33% are temporal. Children, roughly 60, it's just the opposite in kids. I don't really see a lot of kids, so I'll be frank in that. I don't know what's since been out about the children's aspect of it, but there you have it. As far as the symptoms that you often see with supratentorial tumors, and many of those that you saw, of the examples that I showed you were supratentorial, but increases in intracranial pressure, headache, vocal deficits, weakness, dysphagia, which each of those patients had some element of these symptoms. Seizure is always one that is, seizure and headache seem to be the most common initial indications of something more nefarious going on. Posterior fossa tumors, headache due to ICP, dizziness, nausea, vomiting. Anytime there is localization in the vermis area, you have kind of that broad base, big ataxia because of the ventricular area. Nystagmus is demonstrative of brainstem involvement. It's not a tumor situation, we have a little girl who is pregnant and she's in the hospital right now on bed rest with a Chiari malformation and a syrinx. So she has the tonsils are actually kind of protruding through her foramen magnum. And she has nystagmus all the time. I mean, it's pretty impressive, but just wait till she has the baby before anything will be done, unfortunately. Unfortunately, depending on how you look at it. Let's see. Like I said, brainstem involvement usually results in cranial nerve and long tract abnormalities. Sites of cerebellar tumors. Presentation, location, size, grade of tumor, neurological deficits are usually 68%, 45% will have motor weakness. A lot of them will have mental status changes, like I said, headaches and seizure. Signs and symptoms of brain tumors, cerebral edema, increased ICP, which is going to result in headaches. Obstruction of flow of cerebral spinal fluid, that's often in the fourth ventricle, you'll see that. The lady Cheryl that has the right-sided tumor, it actually is a schwannoma. We had to watch her for her intracranial pressure. Sometimes, so when I was a tech in radiology at OU, it was very common for them to use intracranial pressure monitors. I think it's just a matter of how the neurosurgeons are trained, whether or not they do that. At Integris, none of our docs do intracranial pressure monitors. We stay on top of the sodium and try and create a hyperosmolar state to decrease the pressure, and we stay on top of the blood pressure as well. And then sometimes we'll do serial BNPs. But another component of these patients that have brain tumors, whether we're on the preoperative side or the postoperative side, is we're pretty stingy as far as the pain medications that we'll allow them to have, because you've got to have good neurological exams, because that's going to be your number one go-to. And then you're like, ICU nurses, there's neurological change, maybe there's vascular involvement or any number of other things. You've got to get on top of it, get a CT, new hemorrhage or anything like that associated with the brain tumor. That might indicate that you're taking a lot that night or later that afternoon, which is happening. It's more of the same. Had some interesting facial pain and weakness situations arise. Again, the nystagmus, even though that was a Chiari on the brain tumor. You guys understand why, I mean, it makes sense why you would have disequilibrium and disturbances in coordination if the cerebellum is involved, right? Pituitary tumors, endocrine dysfunction, visual deficits, headache. Like I said, this is a transphenoidal approach. Our docs don't do a lot of these. They do them, OU will do quite a few. There's a lot of times that people that may have a pituitary tumor can just be managed medically and don't have to have any kind of surgical intervention. Obviously, it depends on the origin. Frontal lobe tumor, so you guys remember the first guy with the big, huge frontal lobe tumor? So inappropriate behavior, personality changes, so he became more somnolent, however I'm saying. He was a little more erratic, that's something I didn't mention, like his wife said that, so more disinhibition. I was thinking the frontal lobe is, it's like the gas and the brakes, right? Well, he didn't have as much gas and brakes, so impaired judgment, he was a little more, she'd never really been afraid to like leave him alone before, but you know, he was cooking something on the stove, she wasn't, the wife lost her certainty of whether or not he was gonna have the judgment to turn off the stove after he got done cooking. Things like that, little things that could be, you gotta think too, in this population, the guy is obese, he's got diabetes, he's hypertensive, he is still a very neat man, very happy, just kind of loving, good person. But all those changes in that kind of population, you could think dementia, you could think with diabetes, you can get some depression if the blood sugar is not controlled, those things could couple in. So as a family, even though they noticed these changes that were slow over a period of time, they didn't raise any significant alarm bells until obviously, of course, when he actually came in. And then you look at that tumor, like when I showed them what we were gonna take out, both of them were just absolutely shell-shocked, which is, it's huge. It was absolutely huge. What do you guys think were concerns that we had surgically? I'll go back to that picture, we'll be on. Okay. So what do you guys think, as far as like looking at that location-wise, what do you think were things that we were really weary of as far as like surgical approach? Exactly. So the optic chiasm and the sagittal sinus were the two big things. I mean, everything is still surgery, but those were the biggest things. We were, that was very tenuous. So I think we spent like 6-7 hours on him. And it's a meningioma, so they're kind of well demarcated margins and everything. We went in bifrontal. We were able to maintain his vision. He didn't lose vision, he actually gained vision. Over time, he also, last time I saw him was a few months ago, and he was doing really well. I mean, he had kind of like the family was excited, and he was excited as well because he was back to his old self. You know, he was more active, like he would help around the house with projects. He was more joking and jovial, like his old self. So that was great. One of the biggest issues, post-operatively, what do you think that might have been? So you've got this guy, obese, heavy, hypertensive, large family, good support system, that's good. We get him out of surgery, we're on the other side, get him out of the ICU, and now we've got this, so he's got this big mass that's been removed. We put his bone flap back on, everything's good. Our biggest issue was keeping his hands, because it was, again, it was the judgment, the inhibition issue, because it was still a frontal lobe tumor. He was picking and picking and picking. He understood logically why he should leave it alone, but we ended up having to take him back for 2 separate wound infections because we just couldn't keep his hands off of it. So that's, it was a task, but he's good now. This is his post-op. So this is about 6 months out. So you can see the brain tissue has filled the space. And then a lot of times we'll get a little pneumocephalus air, sorry, stand right on you. There will be pneumocephalus, like air from surgery to air from the drains, and that can cause massive back and stuff like that as well. All that has resolved, which it should resolve way before 6 months. But I think it's hard to imagine that this was there, isn't it? To me, that's mind-boggling, but that's probably why I do what I do. So, all right, so let's go back. So when you look at this, doesn't that make sense? I mean, everything that we talked about? Parietal lobe tumors, so paresthesia, loss of two-point discrimination, visual field deficits. The gentleman with the, both of them actually, but the gentleman particularly with the small cell lung cancer with metastases to the brain, he had the paresthesia, he had the motor dysfunction, and then psychomotor, like he had seizures. He didn't have any hallucinations, sometimes we get that. Visual disturbances were not really an issue for him either. So CT, MRI, plain films, myelography, PET scans. As far as like intracranial neoplasms, the first place that pretty much everybody starts is going to be a CT. Because if you're in a family medicine clinic or something like that and you have a high suspicion, unfortunately the way insurance is, a lot of times you have to go through the hoops in order to get them to pay for an MRI. And an MRI is really going to be your money shot because it shows, CT is getting better and better, but MRI is really the go-to as far as with or without contrast to show any re-enhancing lesions and things like that. Plain film isn't going to show you anything. It's a waste of time. It's not a waste of time always, but for brain tumors, it is for sure. Did any of you guys have any experience in radiology? Imaging? What is it?
I was a rad tech at OU, and then I did surgery at Spine Hospital.
Awesome. Awesome. Okay. So that will help, and you can help your classmates, right?
If I can remember it.
I'm sure it'll come back to you. So one thing to remember about MRI, if you're ever looking for a tumor with and without contrast, if there's ever like infectious components or they're post-surgical with and without contrast, it'll show scar tissue and residual tumor or tumor outlines. Sometimes we'll get an MRA. There's a lady that we have in the hospital right now, I didn't show her images, but she's an 84-year-old woman who has a known meningioma in the right parietal frontal region. It's been debulked one time. We were concerned about some arterial involvement, but she's also 84 years old. I mean, it's always, she's not having a lot of symptoms right now. We went ahead and got an MRA, which is an angiogram, so it lights up all the arterial flow throughout the brain, the circle of Willis, and then basal arteries, vertebral arteries. So we were worried that there might be involvement of the anterior communicating artery or the MCA. Fortunately for her, she did not have any of that involvement. She just has a little hypertrophy of the vertebral artery, and she'll see IR about that and go on her way, hopefully with just her life in peace without any people doing anything to her brain unnecessary. So resection, craniotomy, stereotactic surgery, that's back to the stealth navigation system that I was talking about. It's literally kind of like a computer system. Like if I had a brain right here and I was looking there, the MRI was there, I'd literally have two metal components that literally I could formulate where my trajectory needed to be to isolate the tumor in the safest route. And you can go through the images and make sure, that way you can try to avoid anything that needs to be avoided that you can. So we're kind of the technicians as far as intracranial neoplasms. We get in, we get it, and we try and get pathology, and then we help get the patient to the post-operative stage, and then we incorporate oncology, radiation oncology, and hematology if needed. Those other players that are going to be instrumental in as far as coordinating what kind of treatment. So really our role is just technical, but then those other players will come in and kind of take the patient through that process. We will see the patient back post-operatively, and we follow them with imaging to make sure, to monitor if there's any new growth depending on the type of tumor that it is. But we rely pretty heavy on oncology and hematology and even the PCP to keep us in the loop if we need to go in. We need to see the patient back and potentially go back in and do an additional resection, and sometimes that happens. we stay away from NSAIDs just because of the increase, it's an anticoagulant. So we tend to go more towards Tylenol, or obviously a lot of these patients have headaches. So we'll oftentimes use Tramadol, Ultram, which is an opioid, or Duracet, which has a little butabol, caffeine, and Tylenol. And those are medications that are not too sedating, but tend to generally help patients with headaches that they have. Steroids is a big go-to. When we see these patients in the ER, and we're bringing them up and we're getting them worked up for surgery, we use steroids a lot because it helps decrease the edema and the swelling around the brain, which helps alleviate a lot of the symptoms. These patients, if they've had a seizure, several of these patients had a seizure associated, the gentleman with the frontal lobe tumor, he had a seizure actually the same day that he presented as well. But we'll put him on, we usually put him on Keppra. There's other agents that you can use as well. Any patient that's had a seizure with their presentation or has a seizure history, they'll be on it long-term and they'll follow up with neurology and they'll decide when to take them off it. We pass that over to them. That any of our patients, whether they've had a seizure or not, just because you're in there and you're messing with the brain and you're changing the anatomy, they're always on anti-seizure medications for at least 2 weeks. That's how our doc does it. Another one of our docs, my doc does it, I should say. Another one of our docs does it for roughly 1 week. We use hypertonic saline and mannitol. Both of these are to increase the osmolar state, and that just helps. It helps maintain the brain tissue as well as keep the edema and the swelling down. So you're kind of try 3 or 4 things. You're looking at pain, trying to control the pain, trying to inhibit any kind of seizure, trying to keep the blood pressure under control, because increased blood pressure is going to increase the intracranial pressure. And then you're trying to keep the sodium and osmolar state in kind of a sweet spot. Our sweet spot that we typically aim for is 145 to 155. And usually sodium, we're looking at 135 to 145 is what the normal is. So we'll put them on hypertonic saline, put them in the ICU, just keep them hydrated where we want them. Histamine blockers, muscle relaxants, those are things you use sometimes. The lady with the schwannoma in the vestibular area, she required a lot of antiemetics and muscle relaxants, but she had temporal mandibular involvement as well. But that was more than anything that was related to just post-operative pain, because when we went in to get a biopsy of her, we went in retrosigmoid, so we went in here, opened up her skull, and accessed it that way. And then when you bring all the temporal muscle, remember how big and meaty it is? You suture all that stuff together, everybody, it hurts post-operatively. So meningioma, got your epidemiology. Gliomas and meningiomas are general supratentorial tumors. Astrocytomas, glioblastomas, oligodendromas. Say that 3 times fast. The patient that came in, this one. So this gentleman, he was the guy that came in that initially had to work up for the right NCA stroke. Okay. And we were talking to the radiologist, talking to the neuroradiologist, talking to the neurologist, talking to the intensivist. We had everybody on board, trying to figure out what was going on before we went in and did anything. Because it's pretty easy to see that there's nothing, you can tell there's pathology there and it's not normal brain tissue, and there's abnormality. You can tell that by looking at it. Just, can you guys see that? Maybe no? it's okay if not, Jake's well gave you these, and this isn't the best imaging, but, so midline, right? You've got protrusion across the midline. Look at how this brain tissue is, the white matter and the gray matter is compared to this. It's grainy like on a TV, like when you have a model picture. It's not supposed to look like that. It's not healthy, that's not normal. So we're trying to figure out what we were dealing with. Again, we were hoping for herpes simplex encephalopathy. When we went in and opened him up and did the biopsy, unfortunately, what we found was atypical astrocytoma. He died within a week. So it was interesting too because his clinical picture, we sent several different samples off to pathology and went and talked to pathologists and looked at the slides and talked to the radiologists because we were all hoping for herpes simplex, which isn't the best thing, but when compared to astrocytoma, it was definitely preferable. There'd be days when I'd go see him pre-op and post-op where he could have a normal conversation with me and it would seem like absolutely nothing was wrong at all. And his wife would be there and you could see his family just going through this emotional roller coaster because we couldn't give them a formal answer immediately and we weren't sure what we were dealing with either, so I know that was frustrating for them. But even when we got him out of the ICU and we stepped him down to the floor, I'd go see him, and he'd shake my hand, and he would go through a mental status exam and do pretty good. I could come back and see him an hour and a half later, and he could pass maybe half of it. He would be responsive, but very in and out. And I discharged him on a Thursday. We talked to the family. After we got the final pathology results and knew the prognosis, then it was the conversation of, do you pursue treatment? I mean, debulking something like this, it's not really a reality because it's so infiltrated into all areas of the brain tissue. So you're looking at chemotherapy or radiation therapy. Can they do that? Yes. Is it hell for people to go through? Yes, and what was the potential benefit? Maybe they get 6 months. So it was really the conversation had to become about what do you want the time together to look like, okay? And is it worth it? And there's going to be a lot of pain and suffering, and what's the gain? So the wife was she was very strong and reasonable. She had had 2 parents pass of cancer, and that was obviously tragic in its own right, but it did give her kind of some coping skills and a support system, as well as more grounding as to, in America, our medical system and everything, it's the adage of just because you can doesn't always mean you should, right? And she had the insight into the situation that going through all those treatments and all the pain and the agony of that may not be, really wasn't worth it. And Dr. Stetson and I both advised her, that the choice that she was making, first of all, it's her choice, she and her husband's choice. Second of all, it's what I would want for my family. He did end up dying in a very short period of time after that, which, not to be morbid or anything, but have any of you guys ever had to have a conversation with somebody about whether or not, what kind of decision they're gonna make about their loved one? Have you? Thought about that?
Had it to me.
What's that?
I've had that conversation with a physician.
Yeah. That's good. I mean, it's not good.
Yeah.
But the reason I bring it up is because, so, like I said, I graduated in December of 2015, and one of my colleagues, there's 4 PAs, 2 of the PAs have been collectively, between the 2 of them, practicing for like 20 years. Lee and I, we've only been out, for a year and a half. And, you're gonna have those conversations at some point. I mean, wherever you practice in medicine, it's not unlikely that you're not gonna touch on some part of that conversation to some capacity. Obviously, with what we do in the ICU, we have have to have those conversations more often. But kind of wrapping your head around how to approach it and what you feel about it. Are you gonna become numb? How are you gonna engage people in those conversations? And it's hard. It's definitely hard. I think several things that have helped me in dealing with it, because it's sad. I mean, you don't want to see people hurt. The reality is people are gonna die, right? We're all gonna die. We do our best to keep them alive and healthy as much as we can. But I think for me, a paradigm that I have adapted is that, I'm gonna go through that at some point. I hope that when I go through that, I have somebody that's upfront, not abrasive, is forthright with me, with my options, is respectful that I have a choice, but cares too. And I'm like, if I have that, then I will be blessed. And so I try to adapt that when I bridge those conversations with people. I was there only a very short period of time, very green, and I had to call a daughter who was on the East Coast about her mom, about whether or not we're gonna make a DNR. I mean, from our perspective, she had a subarachnoid plea. We could keep her alive, we could go in, we could do a lot of things, but she was in her upper 80s. And the question is, what is life gonna look like afterwards? Is it okay for me to have these conversations, Dr. McNeil? Yeah, I mean, it's real. So I was out in a very short period of time, and I'm on the phone with this woman halfway across the country about her mom, who's on death's doorstep, and we can take her one way or the other. It's their choice. We are respectful of that, and we are more than forthright with what we think we can do, but it also comes back to the question of what is the quality of life afterwards. This particular lady had Alzheimer's, she had dementia, she had a lot of issues going on, but she's still somebody's mom, and she's a family member. So I guess I would just, I would encourage you for yourself to think about it personally, and if you can figure out a paradigm for yourself of how you can go be that healthcare provider and that practitioner that is there and engaged with them, that's not overly emotionally involved, because then you're not doing any good, but is also present with them, because they need somebody that's going to be forthright with them, but be sensitive to that. And then another thing that somebody told me once was that there's a young lady who had been through several treatments of cancer, had been on death's doorstep, and come back, and it's always stuck with me. She said, sometimes ultimate healing is in passing, is in death, and there's been several times when I've shared that with patients, appropriately so, when you see them hurting and kind of vacillating, looking through what to do, and it's almost always, it's the families where they're all of a sudden in a situation, they didn't expect it, nobody's had the conversation, nobody knows, and nobody wants to make the decision for mom to be DNR, or dad, or sister, or brother to be DNR. So that's why I say, if you get in advance drafted, it's a gift for you and for your loved ones. Nobody likes to make that decision. But anyway, you might stick that in your pocket as far as be the person that can be there with them through that, advise them respectfully so, it's their decision, give them the information they need to make the decision. But, just be upfront. You have to use the words, this might be a terminal event, or this is probably a terminal event, this is a terminal event, she's not going to survive. People will hold on to it. In those situations where it is a terminal event, and it's a matter of, yes, we can keep them alive, but they're going to be vegetables. You don't have to say that, of course. But any little thing that might just be a brainstem reflex for an anoxic brain injury or something, like someone who's never going to be anything but on the machine,